Get a lot of nasal sprays, antibiotics, then they get surgery, and then the whole thing is revisited again, nasal sprays, antibiotics, and there's really no strategy as to what's really happening. But if you speak to a rhinologist, for many years now, we acknowledge that there are a group of phenotypes that we treat very differently from other types of sinus disease. But we've never really put an overarching structure to this and how really we think about it. And I was very pleased to be involved here in two groups that took on this, and I'll show you the breakdowns of how this eventually formulated. But one group was that with Brent Senior, Jessica Grayson, Eri Mori, Claire Hopkins, and we wrote an article in JAMA Otolaryngology about this. And the other group was Witzke Fockens with Valerie Lund, who took it on as part of the EPOS 2020. And broadly, they're very, very similar in how they're going to propose we think about our current knowledge of sinusitis. So let me go through here. I want to discuss then what is the way in which many of these peak bodies are thinking about sinus disease. And the whole idea of doing this, so why is this important? Well, I think by discussing how we describe CRS populations, it allows us to really help educate people about what sort of treatments are suitable. I mean, if you look at even America right now, I mean, you can't think of a marketplace with where on one end there's people promoting balloon dilatation devices, ultrasound and other phenomenons in the nose, right through to biologics, where the entire condition and the indication is still CRS. I mean, they are so different treatments that it's, I think, for someone young joining our profession now, it must be very difficult to work out what really should be applied and when. So the first group of the classification is just this very simple concept that we have patients who have primary CRS and the other group is secondary CRS. Now, this is a very simple concept. It just means that if you have primary CRS, your condition is a respiratory disorder. It's not part of some broader autoimmune or immunodeficiency phenomenon going on in the body. There's not some other disease process like cystic fibrosis. You just have a primary chronic airway problem. There's nothing else happening. There's no other sort of issues going on. It's a respiratory disorder. And that's what it is for the majority of the patients that we see, that they really just have isolated disease. Now, it is a very simple structure. The first layer then is what's the anatomical distribution? So the anatomical distribution is very important because, Moaz, when I was going through training, somehow everybody who had sinus disease, chronic sinus disease, had to get medical therapy before they got an operation. They always had to max out on medical therapy before they then went into an operation. Now, the problem with that is that didn't make sense for many conditions. And then at other times, I thought surgery was employed too early. And when other times surgery should have been the first thing that they went to. So we had no way of really communicating this. And I think this is a really important concept. When we talk about anatomical distribution, it's referred to as localized or diffuse. And what localized is referring to is that the pathology, the inflammation is confined to an anatomical subunit. And when I say anatomical subunit, I mean a functional subunit of the nose. So we all know that the sphenoid drains through the sphenoethmoidal recess, the posterior ethmoid through the superior meatus, but then we've got the middle meatus, which drains the frontal, maxillar, and anterior ethmoids. They sort of come together. And the left and right sides are not connected, really. They are separate systems. And this is, I guess, why bacterial sinusitis is unilateral. But they are separate sides. So if you have a unilateral condition that's confined to just your anterior 3 sinuses or just your sphenoid, you have what's called a localized condition. It's anatomically local, means that actually anatomy probably plays an important role in what's going on. Now, we've said here loosely this is mostly unilateral, and of course that's because I can imagine there's a few patients out there that have like an isolated left frontal and a right sphenoid sinusitis. I mean, that's possible, but the idea is that it's anatomically restricted, and therefore anatomy is likely to be a major factor in the pathogenesis. These patients inherently then are going to get surgery early in their condition. Let's talk about diffuse patients though. So diffuse is the opposite. These are patients in whom have widespread inflammation in their nose. It doesn't mean pansinusitis. It just means it just doesn't follow an anatomical pathway. So they might have patchy ethmoid change, a little bit in the sphenoid, a little bit in the frontal, maybe you know, it's a patchy arrangement. It doesn't have to be severe. It just means it's patchy. It doesn't follow an anatomical unit. And the concept that osteal occlusion and anatomical things are very unlikely in this group. The minute you see someone with bilateral disease, they don't have multiple osteal occlusions. They've got really an inflammatory process going on. Now, the next step then is let's talk about the endotype dominance. And actually this slide's a little bit out of date because this slide calls it Th2, but it's, you know, I think immunologists like to call it type 2 now. So I'm going to call it type 2 here. Type 2 inflammation, this is your eosinophilic inflammation that we see a lot in the sinuses. And non-Th2 is just anything that's not eosinophilic. And although that this description is very simple at the moment, we understand that non-Th2 includes type 1 and type 3 or Th1 or Th17 and all these other different types of inflammation. There's really not enough information out right now to separate it out. So it's really just a type 2 or Th2, an eosinophilic or non-eosinophilic. Then let's look at some examples then. So I want to take us through some examples. So an example of a localized condition that is dominated by a type 2 inflammation is an example like allergic fungal rhinosinusitis. I think speaking to a Middle East crowd, I don't have to convince them of AFS as a distinct entity. We see these patients come to us in which they have these expansile changes. It can be unilateral, affecting only one functional group. And here's a classic case of a young boy, highly allergic asthma, he's atopic. He's got this expansile hyperdense mucin in his sinus cavity. And then when we open it up, here on the right-hand side, you get the typical fungal elements. And of course, we believe that this is a condition in which fungal containing mucin sits around in a local functional group and it creates a hypersensitivity reaction. Now, this is a condition in which no medicine is going to make this better. This patient just needs to go straight to surgery. And thus, this localized type of AFS really is a good example of a Th2 dominated localized disease. Let's talk about some of the non-Th2. So these are the classic isolated sinusitis. This is where you get isolated frontal sinus disease, isolated sphenoid, isolated maxilla, the anterior 3 sometimes combined together with the ground lamella separating out the inflammation from a normal posterior sinus. And when you look up at the sinus cavity, you don't see all that eosinophilic inflammation. You just see pus and purulence and edema because it's not an eosinophil or a Th2 dominated condition. Now, these are conditions that really, in my opinion, don't need a huge amount of thought. Most of us can sort this out, whether you do limited procedures, balloons, washouts. There's all sorts of things you could do to these sinuses. With some good medical therapy, it's probably going to resolve. Now, someone asked me and said, well, why does this person not need medical therapy? Well, of course, you still will give this person medical therapy, but the reality is that many of these patients, if they've had a few courses of antibiotics, it's well-directed from culture samples, they've maybe had a course of oral steroids, use some topical care. If that sinus doesn't get better, just simply leaving them on medication for another 3 months is not going to get it better. And that's because there are changes that occur in the mucosa, such as basement membrane thickening and fibrosis, that simply just become medically irreversible. And that's why some patients develop this osteal occlusion disease. Let's go to the next one. Now we're into the diffuse group. Now, the diffuse means that it is primarily not an anatomical issue. It is an inflammatory issue. So let's look at the Th2 groups here. The three classic phenotypes here are a condition called central compartment atopic sinus disease. And if you hadn't heard about that, I'll discuss that now. Classic eosinophilic CRS, and of course, allergic fungal rhinosinusitis. Now, it's very important. I'm showing examples on the right-hand side. So these are phenotypes that have been described in the literature. In presenting this structure, I'm not trying to invent anything new on the right-hand side of this column. I'm just putting them in their place as to how we see them. These are primary CRS conditions. We've talked about localized. Now we're talking about diffuse conditions, and we're going to talk about those that are dominated by an eosinophilic reaction or a Th2 or a type 2 interaction. Now, this is central compartment atopic disease as it was originally described by John Delgadio. These are patients in whom they get this jelly-like edema coming off their middle turbinate, edge of the uncinate here, the septum, and they just get these central thickening changes. They are generally young patients, and their history really is not of terrible sinus disease, but of allergic rhinitis. And then they get a secondary sinus dysfunction, a bit of barotrauma, trapping of mucus, as in this person, because they get this jelly-like edema around the entrance to their sinuses. Now, these are patients in the past that I used to operate on. They sometimes would have grade 3 polyps, and then I'd open their ethmoid cavity and it'd be perfectly normal. In that case, I used to never think about it. But what that patient is this central compartment atopic sinus disease. It is essentially an exuberant rhinitis, exuberant allergic rhinitis, in which you start then to get some osteal occlusion and mucus trapping and mechanical issues with the sinuses. Let's look at the classic ECRS. So ECRS is not the patient who comes to you and says, I had sinus my whole life and allergic problems like the CCAD patient. This patient's in their 40s or 50s and they were completely well. Maybe they had a viral event. And then ever since that event, they've had loss of smell, terrible asthma, fluctuating exacerbations of their upper airway and congestion, and they love prednisone. If you give them oral prednisone, everything settles down. This is, of course, eosinophilic rhinosinusitis. And when we look at the middle meatus in these patients, they look very different. And the scan looks very different. They've got a diffuse inflammatory reaction. Now, this is not a simple allergy. This is an eosinophilic inflammatory disorder, but it's not an allergy. And this is, of course, where biologic agents are being directed. The cousin of this in the lower airway is adult onset asthma, which is where most biologics are being targeted, because this is the group that we obviously have trouble with. And obviously in my world, this is where we've promoted things such as wide sinus surgery. The use of corticosteroid irrigations makes a big difference. Now, the other eosinophilic disorder we should add here, and once again to my Middle Eastern friends, you guys know this very well, allergic fungal sinusitis can be a diffuse or bilateral condition. And it has these classic dark T1 and T2 MRI features. And it's very common for this condition because of the severity of the edema that once one functional area becomes involved, it recruits the next area with swelling and trapping of mucin, and then the whole thing continues around. So AFS we do see as a diffuse condition as well. Now, let's go to our diffuse but non-eosinophilic condition. Now, this is not someone who's just a smoker who's got like a set of cruddy lungs. This is where someone genuinely has an inflammatory disorder of their airway. So they often have inflammatory looking sinus disease. They might have polyps and they have asthma. And one of the features here is that these patients often lack a degree of corticosteroid responsiveness. So when you give them oral prednisone, they really don't think it makes a magic difference like it does in the polyp patients with eosinophilia. And they don't suddenly get their smell back. They will often be slightly older patients, maybe smokers, and they might slightly be obese. There's a tendency for more females in this group. And this is some of Justin Turner's work here that's shown that there's a group of patients that simply have airway inflammation that's not Th2 dominated. And these patients don't do well on inhalers. Their lungs are often not well responsive to simple inhaler therapy. And in my world, these patients can look like polyp patients. Like here, example here on the left-hand side, we have a polyp patient, but often the secretions aren't that eosinophilic secretions. They're a little bit more milky, still very much a diffuse disease. And this is where we've often targeted treatments like macrolides. So for me now, when I operate on someone and they have this sort of picture and then their biopsy comes back showing low tissue eosinophils, I will sometimes abandon a corticosteroid-based approach to getting them right and move them on to things like long-term macrolides for its immunomodulatory effect. So I hope there I've given you a feel about how primary CRS can be divided into simply, is it a anatomically localized condition or diffuse? And what type of endodyne dominance does it have? Is it Th2 dominant or not? And it's amazing. If you just take that very simple overarching classification, you can pretty much place all of the phenotypes that have been described in the last 25 years into that umbrella classification. Let's move on, Moaz, to now secondary CRS. Now, secondary CRS is very important because secondary CRS implies that your problem really isn't a respiratory one. Your respiratory system and sinus diseases become secondarily involved. And once again, it's back to localized and diffuse. This is very important because under localized, you have to then have some other pathology affecting your sinuses that's local. And good examples are here are things like odontogenic sinusitis. So someone here who has this periapical abscess, they don't really have CRS. They don't have non-Th2 or Th2 CRS. They've got nothing to do with that. They don't have CRS at all. They've got an abscess in their tooth. That's why their sinuses are involved. And so this is an example of a secondary CRS to a dental infection. Another example might be a fungal ball. This patient doesn't have anything else wrong with their sinuses, but they've got a fungal ball. And you could also place foreign body here. So they've got a fungal ball or foreign body sitting in their sinus with a secondary reaction. And so that's a good example of a secondary CRS. And of course, this person here, this person doesn't have anything wrong with their sinuses with regards to CRS. They've got just a tumor. They've got a papilloma growing in their sinus, and the surrounding sinuses are blocked by the tumor. So we don't call that, that's not a Th2 or non-Th2. It's got nothing to do with that. The primary problem here is that they have a mass. They've got a growth blocking their sinus. So this is an example of where CRS can just be a secondary event. There's some other local pathology here that's really the primary issue. Now, the diffuse group to me is easier to understand because all medical students, I think, get taught this diffuse idea that, you know, when you read down the list of things that cause sinus disease, it's everything from CF to cilial problems to immunodeficiency. And the reality is that that's rare, actually, even in my practice, it's rare for me to see that. Maybe I don't look out for enough, but it's not common. Anyway, if you have a diffuse problem, and it's secondary, then it's really saying that you've got some other problem in your body. And these are the three groups: mechanical, meaning mucociliary; inflammatory, which is mainly autoimmune; and immunity, which is immunodeficiency. So let's go through it. So examples of mechanical problems are PCD, so primary ciliary dyskinesia, and cystic fibrosis. These are great examples of broad conditions that have many effects on different parts of the body. For example, CF patients have issues with everything from fertility to their pancreatic function. It's not just about their respiratory system. PCD patients have exactly the same, and they really have a mechanical issue with how they move mucus. It's part of a broader body-wide condition. Here's an example of someone with PCD. This is a young girl with chronic cough. You look at her sinuses, she's just got mucus sumping down the bottom here. These are the things we go looking out for, you know, in some patients who perhaps present atypically. And you can see the sort of secretions and things that are happening bilaterally. So if you see a young person has this picture, you have to say to yourself, you know, what's really going on here if this is a chronic state? CF, of course, I don't think we need to introduce anyone to what a CF sinus cavity will look like, hypoplastic sinuses, chronic thickening. Let's go to the autoimmune group. So this is granulomatosis polyangiitis, known as Wegener's. So this is the sort of cavity we see with them. But Wegener patients don't, this is not CRS, this is Wegener's, this is GPA. These patients have lung, lymph node, renal problems, skin problems. Their problem is not CRS, their problem here is that they have GPA, granulomatosis polyangiitis, and they have sinuses being involved in that process as part of a broader body-wide condition. Likewise is true for eosinophilic granulomatosis polyangiitis or Sjögren-Strauss. That's a very similar sort of phenomenon. Let's look at the final one, which is immunity or immunodeficiency. Now, it's rare that I think I see immunodeficiency. There's very few. Most people who present with sinus-only problems are rarely going to have immunodeficiency. Those who have significant immunodeficiency will have infective problems at other places in their body. So those, maybe the few rare ones that we see in the airway are like selective IgA deficiency because it's a mucosal-based deficiency. Combined variable immune deficiency, but once again, you'd expect to see other places in the body involved. And diabetes I threw in there as one to probably put into here as well. And here's a woman with CVID. She's on gamma globulin, but would get these funny flares. It'd be the right side one time, the left side another time, the left sphenoid one time, and the right maxilla another time. Be all over the place, sometimes multiple sinuses together, and she'd get problems in her lungs. And that's an example of someone who's got a CVID. And obviously, success here is never going to be found in opening the sinuses. It's always going to be in treating the underlying immunodeficiency. So let me go on now and just talk about how EPOS took it on. So they followed very, very similar. They said, look, it's localized or diffuse. They talked about type 2, non-type 2. And then very similar, AFS is an example there. They just referred to it as isolated sinusitis, the sort of classic osteal occlusion disease. Then they talked about ECRS, AFRS, CCAD, and then they just referred to the non-type 2 as non-ECRS, which I think is fair enough. The jury's not out yet at exactly what this is, but we clearly see a group of patients who respond to treatments like macrolides, who might have polyps, and they have broad inflammation across their airway, and they're generally non-corticosteroid sensitive. And this is a group that was still sort of yet to fully define, but it's good enough in the literature that we put it in here as an actual group, and we just called it non-ECRS, but diffuse disease. Let's have a look at their secondary. Something very, very similar, localized or diffuse, local pathology. They threw in the same ones that I did there. They called it mechanical, inflammatory, and immunity, and very, very similar groupings here as examples of those broader issues in the body that might present with upper airway disease as part of an overall disease process. So look, I very much hope with this, I'm very open now to questions, but it gives an overview of, I think, how we need to move forward. And I think this is very important because for me, it's very important. If I go back to the previous slide, because this is really the important one. So if someone came to me with a study they wanted to do on biologics that were designed to block IL-5 receptor, I would really try to make sure that these patients who are coming into this trial were diffuse primary CRS without any other systemic problems. They were diffuse and they had type 2 inflammation. These are the patients that are likely to be suitable for that trial. But likewise, if you're going to do a balloon dilatation trial or a simple washout trial or some stretching of the osteo trial, you don't want to have diffuse patients in there. You only really want localized primary patients with isolated sinusitis. They're the patients that are going to suit that type of treatment. So from an academic perspective, I think it's very, very important. It helps us to sort of narrow down what population are we really talking about. And then from a clinical perspective, I think it helps to put in some of the treatments we have now. So if you come in as a young ENT surgeon, you look at this, you can say, which patients is going to require some sort of mini FES early on? You're going to be like, that's localized non-type 2. what patient do I do a mini or a limited sinus operation, but I've got to give lots of corticosteroids to? Well, that might be a localized type 2, like an AFRS, that's just involving one group of sinuses. And then you say, well, who do I give biologics to? Well, it's going to be someone who has diffuse type 2 disease. You know, who might macrolides be suitable to? Or it might be someone who's got non-type 2 diffuse disease. And you might say, well, what's the role of surgery for localized disease? Well, it's very easy. It's about opening up the ostia, washing it out, reventilating it. But then what's the role of surgery in diffuse disease? Well, it's probably not simply just washing out the sinus and opening up the ostia is probably not really going to change things. You really need to consider managing the inflammation here, because that's going to be an important part of getting it right, because we know in diffuse disease the anatomy plays a limited role in the overall picture of what's going on. And so I think if you said, why do we need to change? I think we need to change to allow both academia and clinical guidelines and clinical practice all sort of come together. And I think this will lead to better care for our patients. Thanks very much.
Thank you very much, Richard. Very nice talk. And it really is, with experience, you could look at the way you segmented these conditions, and it really makes a lot of sense. I just want to say before, if you have any questions, you have two choices. The first one is to write it on the chat line. The other choice is that to give me a wave. And if you want to, if you give me a wave, I will be able to open up your microphone, because I cannot turn on everybody's microphone, otherwise it would be very, very noisy.
So can I ask, I've got a couple of things here. Someone asked me, how do I differentiate in polyps? Do I take a biopsy, a systematic biopsy? I absolutely do. So when patients come to surgery, they come to the operation. I don't really do biopsies beforehand, but when they come to the time of operation, I always take a biopsy, everyone. And it's amazing how over time it's changed my practice. Now, maybe I can send Moaz to put up on the list our current structured histopathology report that we use. Actually, I think I can load that, can't I, onto the chat line? I might do that as I speak, Moaz. So our current structured histopath report is how we report all our biopsies. And as the person's alluded to here, I think it's Chakron, you're absolutely right. It's actually at the most basic levels, we just ask for an eosinophil count, and we don't have them do it continuously as a continuous variable. We have them do it in simple groupings, less than 10, 10 to 100, greater than 100. And actually for us, that's been very successful at splitting this out. And I think in the literature, we still have probably this simple greater than 10 and less than 10 as probably the best classification that defines this phenotype. So that's what I would recommend. If you take a patient to theatre, use the opportunity to take a simple biopsy. And if you haven't got your pathologist on board, maybe just tell them, can you give me a rough idea of the number of eosinophils? And if they're keen, then send them my report that I'm about to send you now. I'm sort of doing two things at once here. And I'll load it up here when I get a moment. Let's go on to the next question, Moaz.
Richard, can I ask you, let me just back up a bit. So let's say, we understand the structure of the classification that you're proposing, but I just want to take you step by step. Let's say you have the patient coming into your examination room and start describing symptoms. As he describes symptoms, could you start in your mind trying to allocate this patient to one? So could you tell us in terms of like history, what are the things that makes you go in one direction or try to start classifying this patient under which category?
Yeah, absolutely. So let's go to the primary disease. So the easy one is I ask them about their symptoms, and within a heartbeat, I find out whether or not they're talking about unilateral symptoms or bilateral. And the minute they say they're bilateral, we're down to the bottom group. So they're in the group in which it's almost certainly going to be some sort of diffuse disease. The next one is I then ask them a little bit about their story of when their symptoms started. And if they tell me they've had symptoms their whole life, then I start to formulate the idea that if they were very young, that they might have just simply had, just talking about inhalant allergy, and over time they've developed this central compartment sinus disease. Classic features of that are that they have childhood asthma. They may not complain of classic allergy as what's written in the textbooks, but they'll often have a retained sense of smell. And things like barotrauma are often very common in that group, but their smell is still there. They are often younger, 20s, 30s, 40s. The minute they say to me, I've lost my smell very early on in the piece, the next question I ask them is that when you're given prednisone, does it come back? Because the minute they say to me, oh yeah, my smell bounces back in a heartbeat, a couple of days on prednisone, I've got my smell back and I feel a whole lot better, you can almost know for sure that they're type 2 diffuse disease. And then if they tell you that they really didn't have any problems when they were younger, and it really only started in their 40s or 50s, you can guarantee that that person's probably an eosinophilic rhinosinusitis patient, because they've got adult onset only sinus disease that's corticosteroid responsive and has smell loss. And then you ask them about their asthma. And if they say, oh yeah, my asthma came on around the same time or just before, then you know that that person's got some form of adult onset eosinophilic sinus disease. So that's how I sort it out. If they're a little bit older again and they don't have good control and they don't respond to corticosteroids, and then I might put them in that bottom group. I was going to think, one more thing I was going to say about all of that. Childhood asthma is probably the other big one I look out for. I mean, they'd be the main things, Mawaz. Like if you said to me, how do I sort out those diffuse type 2 groups? It's really that sort of basic breakdown that I spoke to you about then. Their age, onset of the disease, their timing of their asthma. Here's the one thing I was going to say. I almost dropped it out of my mind. The other thing you have to look out for is it's easy to get it confused. So you will see some patients who'll say to you, oh yes, I've had terrible allergies when I was younger. And then they're 50 now, and they say, yes, but my asthma came back. So the patient who tells you that my asthma came back in my 40s, that's not allergic. That's more likely to be someone who does have eosinophilic disease, like a ECRS, but they just happen to have allergy as well when they were younger. And the jury's out on that thing. So they often say, look, I had allergies when I was younger, then it all went away for a while, for 10 or 20 years, and then came back. I think that person, in my mind, is probably someone who's got eosinophilic CRS and just happened, like 20% of the population, to have a bit of allergy when they were younger. But anyway, Muaz, that's good. What were you going to ask?
Does the history of, if somebody tells you you have inflammatory bowel disease, does that figure into anything? No, it's just